So what do we say? We use the 500 bag. I said hypothetically, the patient does not have an order for fluids. They just have an order for the Csun, right? We use Csun. So there's no order for this bag at all, or this saline. Is this still a medication?
Yeah.
Yes, it is. Yes, it is, right? So can I rightfully then tell this pump to infuse any of this med?
No.
No, I can't. But this is the most common isotonic solution that we use. So I only use this to make sure that the patient gets all of this drug.
Oh.
So it's readily understood. But if I was to program this pump to say, yeah, you know, my provider says give this at 100 mLs an hour, or give it at 200, it's a 50, it would be at 100, it's over 30 minutes. Give this at 100 mLs an hour, right, for each dose. And then you know what, I just want to flush the line, so I'm going to program the pump to then switch to primary and give 50 mLs. Is that within or outside of our scope?
Within.
That's outside of our scope.
Oh, I see my nurse doing that all the time.
You're gonna see nurses do that all the time. You're gonna see nurses do that all the time. But if you pause to think about it, is this a med?
Yes.
Can I tell, or can I decide what rate of any drug goes into a patient? No, you can't. Be careful. Go ahead,
If you
Genevieve.
did want to flush, you would have to just IV flush the line.
That a girl.
Okay.
So I'm not gonna tell the pump, after this med is done, I'm gonna take this, I'm gonna flush the line. Now, there's one other key point to this, right? Go back to that logical thinking. What's still in this primary line? Why?
Because of the length after it stops the stuff below the little
Okay,
machine.
so this is where I didn't want to necessarily go, right? And I'll just kind of stop it there. But the reality is no matter what, you're really never gonna get all of this med or all of this volume into that
That
patient.
makes sense.
Some of the best practice facilities have begun to look at protocols that are nurse driven, that understand everything I just taught you and say, dude, this actually makes no sense. There's 50 mLs in here, it's going to begin to dissolve into this line and also dilute into the primary volume, right? So I know that there's 50, I'm gonna tell the pump there's 50, but this line is still 20, so some of it is still being diluted or lost, right? So to get most of that med in, I'm actually gonna create a nurse-driven protocol that says what Edith just said she sees all the time, which is after I tell the pump to give the 50 at 100 an hour, I then tell the pump to give the primary for like a full volume of maybe 30, whatever it may be, whatever the protocol decides, at 50 an hour, whatever the rate is, so that it gets some of this to push the rest of the drug in. That's very dangerous though, because what if I'm dealing with a patient that's at risk for fluid volume overload? Or what if I'm dealing with a patient that has multiple meds and you need to give other drugs? Will you see what Edith described? You'll see that every day. You will see it every single day, okay? Everybody with me? Okay, but the reality is you're just never really gonna get all of this in, but our goal is to get as much as possible in. But I'll tell you, the number one way to not do it is to set it up in a primary line, okay?
So you're saying back prime because look, you're definitely gonna lose some. You might as well only lose it where you can't control it.
Totally agree. That's my approach, and that's the best practice. Go ahead.
Okay, so when you prime the line with the primary, you're technically are giving the patient some of that drug.
You are indeed. You are
But
indeed.
that's okay because
It's just considered standard operating procedure because there's no other way to get through it. And setting up a primary and secondary is standard practice.
okay.
Yep, great question though. Okay, does everybody get that? Did I go over anyone's head? You guys can tell me the truth. Okay, so the other key piece from a safety perspective is to always also check what? Starts with a C. What's in this and what's in this can also,
Compatibility.
good job. You have to check compatibility. So let's say this primary bag was continuous IV infusion, and this was NS with 20 of KCl. What's KCl?
Potassium chloride.
Okay, right? Now potassium is a drug that has a lot of interactions, okay? So if I didn't check that piperacillin tazobactam is compatible with potassium, I set the lines up, I start to infuse, my patients call me, hey, this IV is burning like crazy, and there's something forming in the line. I come back, and the solvent has now turned into, or the solution has now turned into a solvent, and this line is white and crystallized. I screwed up, okay? And I potentially risked harm of the patient. So, to check compatibility, two ways to do it, okay? Who can we call? Our great friends. Call the pharmacy. Ask them, or save them time and just go straight to the what?
Google.
Or not Google, not Google, use a resource, a drug guide. Good job, Nicole. Open your Davis drug guide, or if you're working for a hospital, right, they have an electronic drug guide built into the EMR, so you just check that, and then you would type in this drug, you would type in whatever's in here, and then you check compatibility. A lot of those drug guides are gonna tell you, it's either gonna tell you compatible, incompatible, or it's gonna say undetermined. Undetermined would be through clinical phases, we could go either way. Sometimes it crystallized, sometimes it didn't. So would you put those two drugs in the same line? So if you see undetermined or inconclusive or incompatible, you're not connecting those lines. The only time you would do it is if they're compatible. Okay? You guys with me?
Yep.
Now, okay. This is so much, it's always good. Now, if I had a patient with a single peripheral IV, so normally we would have already put the IVs in, that was what we were supposed to cover today. Next week we'd be doing this. If I had a patient with a single peripheral IV, okay, and I had to give piperacillin, tazobactam, or Csun, but then the patient's magnesium was low. So I wanted to set up another module, okay, another line, and I was gonna Y connect both lines down here, because I only have one port to connect into the patient. Let's just say they had one line, a peripheral IV line in the left arm, okay? So I only have one hub connected to the patient. So I have this primary line, I set up a primary, I set up my Csun. I connect it to the patient, right? Now, my distal Y port, I can still potentially get another line in there. You guys with me, right? So now what do? I check, what do I have to check again? Compatibility, right? So let's add MAG as a third drug. So I have saline, I have Csun, which is two drugs, piperacillin, tazobactam, right? Two drugs here, and then MAG. I could potentially do that by connecting that MAG line, setting it up, and then creating another module, channel B, tell the pump what it is, and then connect it here and infuse into the same line. You guys with me? Okay? Now, if I had a midline, okay? And we'll learn about lines next week. If I had a midline, so peripheral line is a smaller gauge. Midline, now I'm going up the chain, it's a little larger. But a midline is still a peripheral line. So it's inserted in the upper arm and it ends somewhere in the shoulder. It does not come into the superior vena cava or the SVC, okay? So we'll learn about definitions, but by definition, a central line drops into the SVC, okay? I'll teach you something real quick. The turbulence of flow at the SVC is the highest as compared to anywhere else in the body. You have significant volumes, rapidly coming in every minute, okay? So when a central line drops in, okay, that central line is gonna drop in the SVC, which is actually gonna be here, right? It's gonna drop in, it's sitting in that superior vena cava. And if I have a triple lumen central line, central venous catheter, okay? That means I have 3 little ports outside of the patient. Maybe it's a PICC line, maybe it's on the chest, maybe it's an IJ, but I have 3 little hubs to use, okay? Do I still have to check compatibility?
Oh wait, because if you have hubs, they're still all gonna go into the same line
Okay,
inside the body.
so what do we think? Are they all still going into the same line? So those are called lumens, okay? So let's just use a triple lumen, okay? So in that line, okay, I have 3 hubs outside of the central line. So I have 3 different potential lumens to use.
That are also 3 lumens emptying.
Okay, good job, right, Ruth?
Yeah.
I'm gonna come back to that. But inside the line, what is physically inside the line? Is it all just mixing inside the line, or is it dropping into the SVC?
Dropping.
Okay, so inside the line, I have 3 channels, okay? Those are the separate lumens, okay? I have proximal, medial, and distal, right? So inside of that, that's what's physically inside that central line that's going through a major vein, dropping into the SVC, okay? So now I just solved one issue. So we know that they're not physically mixing inside of the central line that's in the body. Now go back to the second point I just taught you. Now where is it dropping into? Okay, so if MAG and Csun are incompatible, It's not the aorta, but it's the superior vena cava, right? And I said it's highly turbulent blood flow. Does incompatibility matter?
Yes.
No.
Oh,
So
because
who
it's
said
so
no?
fast, we'll
Hello.
hang out together.
Is that what you're gonna say, Nicole?
Kinda, yeah.
The rush of flow is so quick that even if they're incompatible, they're dropping into a space that's mixing it so rapidly. So incompatibility in a multi-lumen central line does not matter
Okay.
because it's dropping into the SVC. You guys with me? Go back to the midline, okay? The midline's not dropping in the SVC, it's ending somewhere in a major vessel in the shoulder. Does incompatibility matter if I have a double lumen midline?
Yeah.
Yes, it does. That was the point. That was the lesson.
So the point is, or so the basics is if the area which is the superior vena cava is the most turbulent, anywhere that's the most turbulent,
It's only going to be the SVC. It'll only be if you have a central line.
is where you can technically put incompatible drugs.
Correct, because the turbulence of blood flow is so high that it's just mixing rapidly. But any other multi-lumen line that's not a central line, you would have to absolutely check compatibility. And anything going into the same line, you 100% always check compatibility. Okay, you guys good?
Yes.
Last two things and then you're gonna practice, okay? There are different types of drugs that we give, okay? And there are different types of setups. So this is an example of parenteral nutrition, okay? So this would be one thing, this would be another. So there's PPN and there's TPN, okay? PPN stands for
Peripheral parenteral nutrition.
close. So if TPN is total parenteral nutrition, that'll grow, okay? So partial or total. The only difference between the two would be what?
Where it ends up, right?
Don't overthink this. Pay attention. Total,
Oh, it's all of your nutrition.
hello, there's the answer, okay? So who determines that, Ruth?
The nutritionist?
Okay, you just told me two different people. So choose one. Good job. So this, I'm always teaching you guys about the interprofessional collaborative network, right? So we talked about pharmacy, we talked about the provider's order. So who determines total versus partial parenteral nutrition? It would come from the registered dietitian, okay? So the RD does nutrition. That's their job. Their whole job is nutrition. They're gonna consult and assess the patient and determine their nutritional needs. Then they will then make a recommendation to the provider, which the provider is never gonna say, hey, you're the freaking expert, I disagree with you. You're the expert for a reason. So the provider, unless they see something that's abnormal, they might question it. Go ahead, I'm gonna, go ahead and order that, okay? So parenteral versus total is just what? What's the difference, Ruth?
Does it provide all of your nutrition or only
Or
partial?
part of it, okay? You guys with me? So now, PPN or TPN is going directly into a vein, okay? So in order to give PPN or TPN, which type of vessel do we need to drop that into?
Big one. Blood.
Good job. That's the answer I want you to, guys, you to say today. So the answer would be a central line, okay? Now, you will, in certain conditions, see this in a midline. We'll learn about line types next week, okay? Which is still a peripheral line, but it's larger bore. But for PPN and TPN, you want a central line access, okay? High risk for infection, because what's gonna be mixed in this nutrition? Glucose, vitamins, minerals, all kind of stuff. Bacteria love sugar, okay? Love sugar. So very high risk. Other key piece about PPN or TPN, so you would typically want to use a multi-lumen line. That would very rarely, if ever, only you got no other access, be given through a single line, because once that's connected, you can't connect anything else. So TPN, PPN, as well as blood product, nothing else would ever interact with those two drugs in the same line, okay? Dedicated lumen, or a dedicated line. Everybody with me? Okay? So if I only had peripheral access and I had one line here getting a continuous IV and then the patient needed blood, what do I need? I need another access line. If I had a left IJ and an internal jugular and it's a triple lumen central venous catheter, what can I do? I can dedicate a lumen to the PPN or to the blood. You guys with me? The other thing that's missing here, and always freaking disappears is my filter, okay? So, I'll show you this real quick. It's all good. Just remember what I said, right? Or just keep this somewhere in your Rolodex. When you give, Sadaf, you okay? Sadaf rolled her eyes like, holy shit, what else has God want me to remember? Okay? Sorry, Sadaf, shouldn't swear. Okay? When you give PPN or TPN, what did I say was in here?
Sugar.
Keep going.
Vitamins,
Well, carbs would be your sugar, vitamins, minerals, fluid, volume, hydration, and glucose. Okay? So what might happen to the solution?
It'll go back.
Or it could crystallize. Okay? So anytime we give PPN or TPN, I need a filter on my line. Okay? I'm weird and just crazy. I have a very significant memory. I could tell you what that filter is. I'm not going to tell you, you'll never remember it. But the filter looks a little bit like this. It's a little square. And inside, just like a carbon filter, is going to be a filter physically in here. And it's a micron-based filter. So it filters at the micron level. Okay? So that filter, we would set this up with 2 specific primary lines. One for the PPN or TPN, one for the lipids. Okay? You guys with me? The filter goes on which line? The lipids or the PPN or TPN? Okay, so then when why connect this lipid, which is, this is fat, does it go, so let's say I had this line, okay? At the end of this line, there's gonna be another little connection down here. It's like 5 mLs long. That's the filter. Below the filter is gonna be another wide connection site. So when I prime that line, would I connect that here or would I connect it below the filter? What do you guys think?
Wait, if it doesn't.
So look at, listen. This line is the PPN or TPN. This has the glucose. This has the minerals, the vitamins.
Where is that?
That's the fat.
Okay.
What I'm asking you is, where do we connect the fat? Do we connect the fat above the filter or below the filter?
Below.
Good job. That's what I want you to remember today, okay? Don't worry about what the micron filter is. Just remember that 2 things. PPN, TPN, you need a filter on the line, okay? Because of potential crystallization. And then when you connect the lipids, it has to go below. Trust me when I tell you, I come into rooms and I see the ignorance and they connected the lipids up here and they're freaking filtering the fat out. And then the line is clogging and they're like, well, what's going on? Well, I'll tell you what's going on. You clog the filter with the fat. The fat below, so repeat after me. What's the first thing we need to know? PPN, TPN needs what? And where do we connect the fat or the lipid? Good job. Everybody with me? Who had a question? Last but not least, blood. Blood, we connect with what's called Y tubing. Which one of these freaking lines am I Y tubing? Okay, right? I'll use this one. Okay? Blood product we use with Y tubing. You guys ready? Edith, you good?
Oh,
You
yeah.
gonna survive?
Yes,
Okay.
I'm just sleeping.
I'm still standing up. You guys are too, right? So, I have 2 spikes to 1 drip chamber and then 1 single line, okay? Here's my blood product. It's gonna go up, okay? How do we prime this line? Do we prime it with the blood or do we prime it with something else?
Something else.
Okay, so Ruth, say that nice and loud.
Saline.
Only saline. Only saline, okay?
What about
LR, lactated ringers. So for us on the unit, if you're working OR, you'll be given blood product with LR as well. For us on the floor, it's only saline, okay? Universal solution, no saline. So I would connect this to my saline, okay? I'm gonna clamp this side, okay? So this is not open, the spike is still closed, okay? I'm gonna spike, then I'm gonna open this up, I'm gonna squeeze the saline, and then I'm gonna prime this line out of saline. Everybody with me? I come back to the saline line. I clamp the saline line. I take my blood product. I spike the blood product. I open this up, and I do one thing and one thing only. And then that blood's gonna flow right into here. I have a prime line. Okay? I'm gonna repeat it back. Su Young, you ready? You're gonna help me, and Carl, you're gonna answer the second question. What is this called, Su Young? What does it look like, Su Young? What letter?
Y.
This is called wide tubing. Okay, so young, you ready? How do we prime this wide tubing? What solution do I use?
Saline.
Okay, so walk me through it. So don't worry about this one. What do I do here?
Spike it.
Spike the saline. What's next? Open the clamp. What's next? Squeeze the drip chamber. What's next?
You have to prime it out.
I prime the line. What's last, Soo Young? Come back up and do what?
Close it.
Okay, Carly, you ready? Now I have this line, which is still open. Well, still with air. Carla, what is this going to connect to? My blood product. Okay? I'm going to spike the blood product. I'm going to open this up. And only one thing I need to do. Squeeze my drip chamber. The blood's going to squeeze right into that line. It's primed. You guys with me? What's inside of this? What do you guys see? No.
It's like a gel barrier.
It's a filter. It's a filter. Okay? So this would capture any clots. Okay? It's a blood product. This would capture any clots or any agglutination. I say blood product because what might we be giving? We might be giving whole red blood cells, plasma, platelets. There are multiple different blood products. Okay, you guys with me? Okay. The last thing I'm going to teach you guys real quick, with blood products, there's a process. Okay? So any type of blood product, any phlebotomist here? Okay? You should know this. Okay? Blood product, whether in plasma, platelets, whole red blood cells, partial, whatever it may be, there's a clear process. It would be guided by hospital policy, but it's also dictated by CLIA. CLIA, C-L-I-A. That's the laboratory accrediting body in the United States. Okay? You need 2 identifiers. Okay? So the first step is you need the order from who? The provider is going to say transfuse, right? And they're going to put the order in, and it's going to say to get what test first. What do you need to do? So I don't need human resources. But,
Request for a CBC for.
not a CBC. Well, the CBC would tell me whether I need whole red blood or even potentially platelets. What do I need?
Blood type.
I need a blood type, but what else?
CBC.
No.
RH.
So RH factor would come with my blood type, but what's the order called? So a type and
Cross.
attaboy, Josh. Okay? I need a type and cross, okay? Or a type and screen, okay? So a screen, okay, would tell me what, Josh?
I don't know.
You already said it.
Oh, cross.
No,
Wow.
a type and screen. So,
RH factor.
good job. So a type is my what? It's my blood type, right? So am I O positive, am I O blank, right? Am I A, am I whatever the case may be, right? So that's my type. My screen would be for my RH factor, okay? But specifically, you're gonna see if you're preparing for blood product, a type and cross. What's the difference? So I just explained the type and screen. So anyone that comes into ER that's specifically a female or a trauma, off the bat is getting a type and screen. Why is that? So trauma, we might be definitely giving blood. If they're female, good job. I need to know potentially RH factor and if that patient's gonna need blood and is it gonna be compatible with that baby, okay? A type and cross, now I'm physically giving the blood or the blood product, and what am I doing? What does the cross do? It's a cross match.
The plus and minus stuff?
No.
Oh, like the antibodies that you may have?
There it is, Ruth. So now I'm cross matching what against what? My blood against
Blood you have.
my blood against whose blood? The donor. Okay? So now in the lab, if this is the unit that Shawty's getting, I took Shawty's blood. I know her type. I know her screening for her RH factor. I'm gonna take her blood. I'm gonna take the donor's blood, and I'm physically going to put that through a machine, or I'm going to manually do it, which is antiquated now, and I'm going to cross-match those cells to ensure that she doesn't have any risk of antibody agglutination or cross-matching that's gonna cause clotting or some adverse reaction physically in her body.
So just like compatibility basically.
100%, okay? Type and screen does what?
RH factor.
RH factor and type of blood. Type and cross does what?
Compatibility.
Nicole, did you get that or no? Okay? What does a cross match physically do, Nicole?
A cross match?
What does a cross match physically do?
Test the compatibility.
Who to who?
The donor with the patient.
Good job. Okay, you guys with me? Okay. The last piece about blood product, that's a part of the process, okay? With blood product, to go retrieve this from the blood bank, I need to go down with multiple patient labels, typically 4, okay? I go down, there's gonna be an actual order form that you pick up from the blood bank. First step is, I go down, let's say it's an order to transfuse 1 unit. The blood bank personnel is gonna come, they're gonna go through the entire process. You're gonna hand them the stickers, they take 1 for their records, you put 1 on the sheet that you're gonna take up to the floor, you put 1 on the carbon copy, which goes to the records, and then you take the last to do the check, okay? You're gonna go through the check. The check is gonna be what? Patient, order, okay? So going back through the 6 rights, right? So patient, order, that's, you're gonna go through the 6 rights at that time. And then what else is very specific to blood product? Unit number, and as well as blood type and potential RH factor, okay? So that's first process. You're gonna do that with the blood bank representative. Everything clears, everything's good. The order matched, everything matched, looks good. You take the blood product, you go up to the unit, okay? Whole red blood cells outside of the fridge, this is refrigerated, is good for how long? 4 hours. 4 hours, you need to remember that. That's an NCLEX question, and it's a practice question. Outside of the fridge, this is good for 4 hours, okay? You go back up to the unit. You need to get this infusing within which time frame?
30 minutes.
30 minutes, great job, Ruth. If this isn't infusing within 30 minutes, has to go back to the blood bank to get back on refrigeration, okay?
How long does it last in refrigeration?
So refrigeration, that's a blood bank question. I don't know, but for us, 4 hours outside of the fridge, and it has to be infusing within 30 minutes. Platelets, okay? Platelets are on an agglutination tray, okay? So if you go to a blood bank, you'll see this, okay? They're in a warmer and they're in an agitator. So they're physically sitting on these individual like cupboard platforms, yeah, right? And it's going like this, constantly. Why? Because platelets, they agglutinate and they aggregate, right? So it's reducing that. So platelets outside of the aggregator, right, or the agitator, excuse me, right, need to be given when? Within 30 minutes, same rule, within 30 minutes. But the thing about platelets, right, that's gonna differ from whole blood, is that you rapidly infuse it. You give it in quickly, okay? Blood, you guys ready? Last piece, and then you get to practice. Blood product, okay? Blood product's gonna go up. You did 1 safety check with blood bank. Who else do you need to do a safety check with? Another nurse. Genevieve comes in with me. We repeat the same exact process, okay? Now, before I start the infusion, vital signs only, okay? I check vitals. I also do what? A physical assessment of their heart and respiratory, their lung function. So cardiopulmonary assessment. I'm gonna auscultate the lungs, I'm gonna auscultate the heart. Because the potential for fluid volume overload or the potential for what? A transfusion reaction, which would back up into the lungs potentially exists. So I check vitals pre-infusion, then when?
30 minutes after?
Right, the nurse
Okay,
right before.
so hang on. So before the infusion, then when?
Maybe 15 minutes.
First 15 minutes, then when?
Hours.
Q30 times 2, then Q1 until complete. You guys ready? Pre-infusion, okay? First 15 minutes, so after 15 minutes of the infusion. And also the key piece with blood, okay, is you stay with the patient. You have to stay with the patient because the likelihood of reaction of acute hemolytic reaction is within the first 15 minutes. So you stay with the patient.
Just for those 15.
Yep, okay, ready? So pre-infusion, okay, then after the first 15 minutes, everything looks good, you can leave the room. Then you would set the machine, the vital signs machine, to Q30 times 2, and then Q hour times 1 until infusion's complete, okay? After the infusion's complete, you need to recheck vital sign. No, just once after it's done, which is the following hour, okay?
After.
So then that transfusion record, which still exists on paper, that's one of the things that still is on paper, but some people, you transcribe it into the EMR electronically, you would have to put all those vital signs into the EMR, okay? I'll repeat it one more time. Pre-transfusion, then when?
15 minutes.
Then when? 2:30 times Q 1 hour, and then when?
An hour post.
At the end, okay? The blood products, we have that Y connection. In the first 15 minutes, if the patient experienced a reaction, what do I do? Immediately stop it, okay? I go back to my Y tubing. I immediately stop it. I'm gonna clamp the bloodline. Do I open this and begin to run the saline?
No,
Why, Ruth?
because it was fluid overload, that's why they're.
No, keep looking at the line. Go ahead, Jacob, nice and loud. There's still blood in the line. The patient has any reaction. Stop the infusion, disconnect the line immediately. You take the entire setup, it goes into a biohazard bag, and you return that back to blood bank. Blood bank will then test that blood for a potential incompatibility issue that was missed in the cross match and any other testing that they do in their protocols. You would document it as a potential transfusion reaction, and then you monitor the patient per the provider. So what could be a transfusion reaction? Itchiness at the site, is that a reaction?
Yes.
Potentially, right? It's gonna be up to you to critically think, is this a true reaction? Or is this just the patient experiencing a little bit of discomfort, right? What else? Give me some.
You said a gluten
So how would I know that?
like it just gets thick.
So if that was with platelets, right? If the platelets are glutinate, right? So I could potentially be forming some sort of a clot, right? Inside the line. So the patient what? Might have the immediate dyspnea, right? So I just throw a clot into that line, right? Okay, what else? You'll learn about, hemolytic reactions. Tachycardia is one. What else? Go back to your vitals. What else are you checking? So what's the first vital sign we check? Temperature. Are they becoming febrile? Yep, potentially. What else? Lung sounds? Might be hearing some rails, some crackles. Okay. Anything else? Skin. Rash. Might be having a severe rash. Okay. Most common, okay, febrile. Skin is beginning to change color. I've got urticaria, it's itching, right? I begin to have a large rash, which then causes shortness of breath, and I'm backing up into the lungs. I assess the lungs, I'm hearing it. That is key to an acute hemolytic reaction. That patient, that's a medical emergency, okay? Right? So you stop it, goes back to blood bank, you document the reaction. Now, if the patient has any other expressive symptoms, you're gonna have to determine whether or not the patient's having a reaction, okay? You'd stop the blood, maybe call the provider, hey, this is a little iffy. The patient's got some redness at the site, and I assessed their lungs prior, they were cleared throughout, now I'm hearing some rails, okay? What would you like me to do? Go ahead and stop the blood. Give IV Benadryl 25 milligrams times 1, okay? You guys with me?
Yeah.
That's blood products, okay? Any other questions?
Is the reaction due to the blood or the patient or both? Like when they go back to the lab and test it, is there something wrong with the blood?
So it could just be, so with hemolytic reactions, there are multiple different variations. So there are some that actually may be expressed days later or hours after the fact, but the most severe would be an acute hemolytic reaction, which would be an incompatibility between the two blood products.
And that can happen even if you're like O positive.
Yeah.
Same kind
Yep.
of blood.
It could be an antibody issue that you've been exposed to previously. Yep. Okay?
Would this have some sort of anticoagulant in it?
No, that's straight whole blood. Yep. You guys good? So blood products, we're gonna just walk it back through real quick. What's the tubing called that we need for all blood products? How do we prime a Y tube?
With normal saline.
Saline first, right? Squeeze the drip chamber, comes through, prime the line, then what do? Clamp it. Take the other Y connection, spike my blood product, and then squeeze the drip chamber. Walking through process for us, okay? Whole red blood is good how long outside of the fridge?
4 hours.
Has to begin to infuse within
30 minutes.
If not, it's going back where? Back to the blood bank, okay? Vital signs. Pre-infusion.
Pre-infusion, 15
15
minutes
minutes,
after,
30
30
minutes.
So now up to 4.
And then 1 hour.
Good job, okay? That all has to be documented.
So this gets infused within those 4 hours. What about, you said the platelets takes how long? You said it has to go in.
So blood products are gonna vary. So plasma and platelets will be different, but both those are typically rapid infusion. You go based upon the order. Yeah, which would typically, or there'll be a standing order from the facility you work in that says throwing platelets at 500 an hour, throwing plasma. It's rapid.
Okay, got
Like you're infusing it within like 15 minutes.
Oh, got it, okay.
Okay, you guys good?
Yes.
Okay, look it. I'm gonna take this down. You guys are now gonna come and spread out with the poles and the pumps. You're gonna set up everything